All right. Well, we are at 8 o'clock. So welcome to Department of Medicine Grand Rounds. We're delighted to have Dr. Lindsay Clark from Geriatrics to be our special speaker today. And introducing Dr. Clark will be Dr. Asthana, who as you all know, is the division chief for gerontology and geriatrics here. Sanjay, I'm handing it off to you.
Thank you, Dr. Snap. Good morning, everyone. It is indeed a pleasure to introduce today's speaker, Dr. Lindsay Clark. Dr. Clark is assistant professor on tenure track in the Division of Geriatrics and Gerontology. She's also a staff neuropsychologist at the Madison GRAC. Dr. Clark is a neuropsychologist, a clinical neuropsychologist by training, and is nationally acknowledged for her expertise and research in disclosing AD biomarker results to people who are at the risk for the disease or those who have dementia. Dr. Clark received her master's in neuropsychology from San Diego State University and got a PhD in clinical psychology from the same institution. She then moved to UCLA Cernal Institute for Neuroscience and Human Behavior and did an internship in adult neuropsychology. From there, Dr. Clark came to University of Wisconsin and did 2 postdoctoral fellowships. The first one was under Dr. Sterling Johnson's mentorship at the Wisconsin Alzheimer's Institute, and it was an endowed fellowship from Lou Holland Sr., and she was the first Holland postdoctoral fellow at UW-Madison. It's one of the most successful fellowships in dementia research at UW. Her second postdoctoral fellowship was at the GRAC as an advanced geriatric fellow, and she continued her training at the GRAC with Dr. Sterling Johnson. Dr. Clark is a very productive scientist at this very early stage of her career. She has already published over 70 peer-reviewed papers in very high-profile journals in neuroscience and Alzheimer's research, and she's either the first or the last author on 20 of them. Dr. Clark's research has really attracted national attention, and she's among a handful of scientists in the area of disclosure research. She has several grants funded. She is the site PI of an R01, which is performing cognitive testing in people who are normal and also those who have cognitive disorders. She's also the recipient of the ADRC's Rec Scholar grant. She is a leader of the neuropsychology service of the ADRC, and she's a co-I on 5 additional R01s, and these efforts are anywhere between 5 to 10%. So she really makes major contributions locally, nationally, and beyond in the area of disclosure research. She's very active in training our learners who go through our clinics, medical students, resident fellows, even some faculty, and is a popular presenter locally, nationally, and beyond in the area of Alzheimer's research. So I'll hand it over to Dr. Clark. Dr. Clark.
Thank you so much, Sanjay, for that introduction, and thank you for the invitation to be here today. I'm really excited to share with you all the work we've been doing related to Alzheimer's biomarker testing and the personal implications of early detection. Before I get started, I wonder if any of you have wanted to learn more about your own personal risk for Alzheimer's dementia, and if so, why? If not, why not? Those are some of the questions that we'll be exploring today through the work I'll be sharing this morning. I do not have any financial disclosures related to the talk today. And I've structured this presentation this morning in 3 parts. The first part, I'll provide some background about the clinical and biological definition of Alzheimer's disease. I'll share about current available biomarker testing and the ATN framework, and share some research on the clinical utility of biomarker testing. Then I'll spend a significant amount of time talking about the psychological and behavioral outcomes of biomarker testing in Alzheimer's disease. I'll do this through the examples of some of our local research studies, including the Wisconsin Alzheimer's Biomarker Survey and the Amyloid Disclosure Study. Finally, I'll wrap up by talking about some of the future directions in this area of research and some practical considerations if you're thinking about incorporating biomarker testing in your own practice. So when we think about Alzheimer's disease, we typically think about the clinical syndrome. So as we know, when people get older, they may show some mild changes in memory or thinking abilities. But those who have Alzheimer's disease tend to show more significant cognitive decline, initially resulting in the syndrome we refer to as mild cognitive impairment or subjective complaint, objective impairment observed on neuropsychological testing, but still able to function independently day to day. If this is caused by a neurodegenerative disease like Alzheimer's, we do see this progress into a dementia syndrome where the cognitive impairment becomes significant enough that it interferes with a person's ability to function independently. What we know now, though, is that the associated brain changes of Alzheimer's disease begin many years before we see patients in the clinic. These changes are thought to begin about 10 to 20 years before a diagnosis of dementia. And these include development of amyloid plaques, which is a toxic form of amyloid that forms within the extracellular space and forms these kind of sticky plaques and prevents the cells from being able to communicate effectively with one another. Neurofibrillary tangles are the other hallmark feature of Alzheimer's disease. These form from a toxic form of the tau protein inside the neurons, interferes with the neuron's ability to get nutrients from one part of the cell to the other. These two pathologies ultimately result in cell death and atrophy, and then the cognitive decline that we see in the clinic. However, because we know these brain changes are occurring much earlier in the disease process, there's been a real interest in this preclinical stage of disease where people may have these brain changes accumulating but not yet be experiencing the symptoms of mild cognitive impairment or dementia. Historically, we have been able to diagnose Alzheimer's disease clinically with a probable AD diagnosis and then confirm the diagnosis, the definitive diagnosis of Alzheimer's disease at autopsy. But with great strides in development of new testing, we can now see these biomarker or brain changes occurring during life, which is great because ideally we want to be able to detect and treat disease while a person is still living. The imaging biomarkers I'll be referring to today include amyloid PET scans and tau PET scans. Amyloid PET scans measure those beta amyloid plaques, which tend to spread diffusely throughout the brain. Tau PET scans measure those neurofibrillary tangles, which tend to start in the entorhinal cortex, develop throughout the hippocampus, the rest of the medial temporal and temporal lobes, and ultimately throughout the rest of the brain. Structural MRI, of course, is something that we use as part of our clinical workup for memory disorders. And we do look for hippocampal atrophy in Alzheimer's disease, but it may be generally a less specific test for Alzheimer's disease. And also, we may not see these atrophy changes until later stages. Then we can capture the changes in amyloid and tau PET scans. Another modality that is used to evaluate brain changes associated with Alzheimer's disease is by looking at proteins in the cerebrospinal fluid detected through a lumbar puncture. The signature profile of Alzheimer's disease is higher levels of phosphorylated tau protein and lower levels of beta amyloid proteins. The most recently developed biomarkers are blood-based biomarkers, such as plasma p-tau217. These correlate highly with other biomarkers, including imaging and cerebrospinal fluid markers of Alzheimer's disease. And there's many that are still being validated at the moment, but some are commercially available for clinicians to order as part of a workup for those with memory impairment. These are thought to be the biomarker that will be most useful for clinical settings because of the lower cost and lower invasiveness than our other biomarker tests. Another major advancement in our field has been the better understanding of the temporal course of development of AD pathophysiology. So this figure shows biomarker abnormality here on the y-axis and time on the x-axis. And each colored line represents detection of a biomarker representing changes in the brain of Alzheimer's disease. So we see initially changes in the amyloid protein, so beta amyloid plaque development, followed later by development of neurofibrillary tangles, and then followed by neurodegeneration, and ultimately followed by cognitive impairment. There can be some variability here in when individuals with these biomarkers develop cognitive impairment based on other risk factors like genetic risk for Alzheimer's disease or cognitive reserve. But ultimately, this is kind of the hypothesized course of the development of this disease. This better understanding of the course of development of AD led to the National Institute on Aging and Alzheimer's Association to put out a research framework for Alzheimer's disease. And you don't need to read or understand this full table here, but the basic gist is that if a person has a positive biomarker of amyloid, they are on the Alzheimer's continuum. If they have both amyloid and tau positive biomarkers, they would meet criteria for Alzheimer's disease. If a person has just positive markers of tau or neurodegeneration, but not amyloid, this would be considered a non-AD pathologic change. So the purpose of kind of the development of these new tests is to really be able to better differentially diagnose dementia due to Alzheimer's disease and other conditions, and to be able to develop disease-modifying therapies that target the specific pathology underlying AD. This figure is from a recent study conducted by Dr. Carly Cody, who is a graduate student here with Sterling Johnson and Toby Vetthauser. And what it shows is the proportion of tau-positive individuals in the study on the y-axis and how long participants were estimated to have positive amyloid biomarkers on the x-axis. And what you can see here is that the longer people have beta amyloid positivity, the more likely they are to develop tau positivity, which is represented by these colored bars here. Dr. Cody showed that tau positivity was typically detected about 7 years after amyloid onset. In this study, she also showed that individuals who had a longer period of amyloid positivity, so greater than 10 years, and also were tau positive on a PET scan, declined on cognitive performance 3 times faster than those who had amyloid positivity for less than 10 years. So overall, this study shows us that amyloid does develop early. Individuals who have amyloid, the longer they have it, they're more likely to develop neurofibrillary tangles. And the interaction between amyloid and tau is what kind of contributes to the cognitive decline and impairment that we would see in clinic. So biomarker tests have been really helpful in better understanding the development of Alzheimer's disease pathophysiology. But is it useful? Are they useful as clinical tools? Well, this is one of the first large studies that looked to answer that question. It's called the IDEAS study. And what you see here in this figure is that when patients in the clinic were given an amyloid PET scan, and that amyloid PET scan was positive, they were more likely to be prescribed an Alzheimer's-related medication than prior to having had that PET scan. The study also showed that patients were more likely to have a diagnosis of Alzheimer's dementia put into their charts, and there was more likely to be conversations about support, resources, and advanced planning. So this study suggested that amyloid PET can change diagnosis and management of patients with cognitive impairment. Additionally, biomarker tests can be used to help us develop more specific treatments that focus and target the pathology underlying Alzheimer's disease, such as the drug lecanemab, which was FDA approved last year, and the drug donanemab, which is likely to be FDA approved later this year. These clinical trials showed that by administering an anti-amyloid therapy in patients who have cognitive impairment and positive amyloid biomarker tests, the anti-amyloid therapy is able to reduce those amyloid plaques in the brain, and there is a slowing in the cognitive decline over time in those patients compared to those on placebo. Now, there are some issues related to these therapies, including access, eligibility criteria, cost, side effects. I'm not going to have time to go into all of those today, but I just want to bring up this point that biomarker testing is likely to become a part of our workup for those with memory disorders as more treatments come down the pipe that'll really be focused on modifying the underlying amyloid or underlying neurofibrillary tangle pathology in Alzheimer's disease. All right, so that's my whirlwind overview of where we're at in Alzheimer's disease research, generally as far as biomarker testing goes. Next, I want to switch gears and talk a little bit more about the psychological and behavioral outcomes related to biomarker testing. So we developed a survey as part of our Wisconsin Alzheimer's Disease Research Center and Wisconsin Registry for Alzheimer's Prevention Studies. We administered this survey to over 300 of our participants who were in those longitudinal cohort studies. And these participants ranged in age from 45 to 89. 44% of them identified as Black or African American, and the rest identified as non-Hispanic white. And we were really interested in understanding in those who maybe have a risk factor for Alzheimer's disease, or they're involved in Alzheimer's disease research but aren't yet experiencing symptoms. Are they interested in learning biomarker test results? And if so, why? Because we're thinking about that kind of window of moving backward into this preclinical AD stage. So what we learned from our initial publication in this of this study was that 85% of our participants were very interested or were interested in biomarker testing and disclosure. About half of them were very or extremely interested. Those who had higher positive attitudes towards medical research and more concern about Alzheimer's disease were more likely to be endorsing very or extremely interested in biomarker testing and learning results. We also saw that our Black participants expressed a greater interest in enrolling in biomarker studies when those results would be shared back with them, showing really that importance of kind of transparency between the research and the community members, or the researchers, sorry, the institution and the community members. And we also looked at some of the themes that arose for, why people might be interested in learning results or getting biomarker tests, or why they might not be. This is a table from a study that was published by my collaborator, Dr. Fred Ketchum, who's a neurologist and anthropologist here at UW. And he found that the themes motivating willingness to enroll and learn results was a desire to know those results. This might be related to a desire to understand their own personal risk or to plan for the future, and support for the research, so wanting to support research studies. These are research participants, so that theme comes up quite a bit. Themes associated with not being as willing or not as interested in enrolling in biomarker studies that disclose results. A couple were related to the testing itself, like worry about the physical harms of testing or the burden of getting the test. And others were related to learning the result, like anxiety about learning the result, questionable utility about what the result would really provide, and concern about stigma related to the result. In the total sample, we asked participants why they would be interested if they were in learning their results. And the top two reasons in this sample was to inform lifestyle changes to help prevent dementia and to reduce worry if the results do not indicate a higher risk for dementia. We also asked participants kind of hypothetically, what would you do if you learned a high-risk biomarker result? What would happen? And we gave them a lot of different options. 25% of the sample expressed that they would be concerned about being treated differently. 40% endorsed they might feel upset, sad, anxious, or nervous. Most of the participants would tell those results to a loved one, and most participants said they would make changes to diet, exercise, mental stimulation, or stress reduction activities. We also looked at what factors, contextual factors about participants may predict this anticipated psychological impact like distress, stigma, or cognitive symptoms, and what factors may predict anticipated behavior change. We found that lower internal health locus of control, or feeling like you have less control over your own health or your medical care, as well as feeling like you're at higher risk for Alzheimer's disease, was associated with anticipated psychological impact. We found that younger age, Black racial identity, perceived susceptibility to AD again, perceived benefits to testing, like belief in AD modifiability, and cues to action, like having other people around you doing brain health-like activities, were more associated with higher anticipated behavior changes like planning or risk reduction activities. So this study was really helpful. Again, we learned a lot about our participants, their interest, some potential anticipated reactions to learning high-risk results in this sample, but we also recognize that these are hypothetical vignettes. So we wanted to actually do a study where we provided results back to cognitively unimpaired adults in our research cohort, and again, ask some similar questions. So here are some broad study aims in the Wisconsin Amyloid Disclosure Study was to assess feasibility of conducting these visits, psychological reactions, and preliminary behavior outcomes. I conducted this study in collaboration with Dr. Nate Chin and Dr. Claire Erickson, who was a graduate student working in our lab at the time. This was all participants who are in the WRAP study under the PI of Sterling Johnson. So the total sample in this study was 99 participants. About a third of them were elevated, and about 2/3 of them were non-elevated on their amyloid PET scans. They were on average about 72 years of age. 2/3 women, 2/3 higher level of education. 95% of this sample was white, and 65% had a family history of dementia. And there's no differences between those who learned elevated and those who learned non-elevated results in these demographic characteristics. This is a depiction of the study procedures. This study was about 9 months long in total. It included 3 visits. The first was an education visit where we provided some background about Alzheimer's disease, amyloid PET results that you can learn, and some additional information kind of related to AD risk. The second visit involved providing back the results of an amyloid PET scan. And the third visit was focused on dementia risk reduction counseling, where we provided participants back some information about their own modifiable dementia risk factors, and we helped them to identify and set a SMART goal related to brain health. We then had a couple of telephone follow-ups, just assessing some of our longitudinal outcomes. So in this sample, again, we asked their reasons for learning amyloid PET results, and these were the top 3 reasons here. 1, a desire to contribute to AD research. 2, a desire to inform preventative measures to reduce kind of overall risk for dementia. And 3, a desire to participate in clinical trials. Other frequently endorsed reasons included knowing more about their risk of developing dementia, curiosity, to put their mind at ease if they received a not elevated result, and to help arrange their personal affairs. So again, very strong on research here. Again, this is a kind of a biased sample of research participants, but some additional interest here in informing kind of behaviors to reduce overall risk for dementia and to plan for the future. In our education session, we we gave a quiz about baseline knowledge of AD and amyloid PET scans and some other related information. We then provided a 10 to 15 minute interactive education session using PowerPoint slides, and then we re-administered the quiz after the education session. And we found over here on the right that our participants in general before the education session were really strong in their AD knowledge. But that despite that, they still showed significant improvement in their knowledge after this brief education session. And the main areas that they grew in knowledge on were their causes of dementia, significance of the ApoE genotype, which is a genetic risk factor for late onset Alzheimer's dementia, and the lack of existing legal protections against discrimination on the basis of biomarker tests. The disclosure visit was led by one of our study clinicians, either a geriatrician or a nurse practitioner. It started with some pre-disclosure questions asked by the clinician to gauge the person's experience with Alzheimer's and the reasons they wanted to learn their result. The clinician then provided the results and then asked some post-disclosure questions to ensure comprehension, meaning of the result to the person, and any concerns that they had. When a person had an elevated scan result, this is generally the language that we used. We provided the result back in like a physical copy of a document that had their result, as well as an explanation of what the result means. This is what we shared with them, that the result means that the scan indicated amyloid plaques in their brain, that they're in an increased risk for developing dementia, but it doesn't mean they have dementia or have Alzheimer's disease at this time, and it doesn't mean they'll definitely develop dementia from Alzheimer's disease. We used a metaphor of cholesterol to try to distinguish the difference between risk and diagnosis. And then we also let them know that we couldn't provide information at this time about the exact amount of risk. So it's like exactly when they would start experiencing cognitive symptoms. When a person's scan result was not elevated, we let them know that means the scan did not detect amyloid plaques in their brain. It's possible that they're present, but maybe not at an elevated level. We let them know they're not at an increased risk at this time for Alzheimer's dementia, but we also provided the caveat that this is one point in time and that they could still develop amyloid plaques or dementia in the future. Most participants comprehended the meaning of their result, and there was no difference in comprehension between those who learned elevated and not elevated results. We also looked at what issues came up during the visit with the clinician. The clinician asked a few questions. For example, participants, regardless of result, indicated they were likely to share their result with family or friends. Very few had concerns about the accuracy of the result. Similar rates of concerns about discrimination or privacy across the elevated and not elevated groups. Differences we did see in was that those who learned elevated results were much more likely to change some of their behaviors than those who learned not elevated results. And those who learned elevated results had more questions about the result or the result itself. Both groups had similar questions about risk of having Alzheimer's disease in the future. We asked participants some questions to gauge their satisfaction and kind of utility of this process. And a majority of participants felt that learning their amyloid result was useful. All participants felt we should continue to offer these disclosure visits in the future in our study, and no participants regretted learning their amyloid result. There was a little bit of nuance here. This was on a Likert scale for the regret question, and there was slightly more elevated participants who responded neutral to if they regretted learning their result versus non-elevated were more likely to indicate strongly disagree to regretting learning their result. But still no endorsement of regret and no difference in satisfaction ratings across groups across participants who learned elevated or not elevated results. So psychological outcomes. When we first started this study, there was concern that people were going to be really distressed after learning these results. So we really wanted to be rigorous and assess this long term. There had not been any studies that had looked at this over a longer period of time. There had been some studies looking at maybe 1 month after or 3 days after learning a result. So we measured depression using the PHQ-9 on the left here and anxiety using the geriatric anxiety scale on the right. And we measured these at 6 time points, 2 that were before participants learned their results and 4 that were after participants learned their results. And ultimately, we saw no increases on these measures of depression or anxiety, or I don't have it pictured here, but we also used a measure of suicidality. And there were no changes over time. And there was no difference between those who learned elevated or not elevated results. And there was really no one who was endorsing symptoms up into like the moderate or severe ranges. We gave a couple of other psychological measures, including the impact of event scale, which is a measure that's often used in the PTSD literature. And initially, at like 1 to 3 days after learning results, those who learned elevated results endorsed higher rates of intrusive thoughts and avoidance on this measure than non-elevated result participants, but this decreased over the course of the study, whereas by the end of the study at the last time point, they really did not differ between groups. We also gave a measure of test-related distress from the genetic literature. It's called the impact of genetic testing in AD, which we modified for a neuroimaging result. And we did see that those individuals who learned elevated results had higher endorsement of symptoms on this measure, and that persisted over time. This is a measure more about distress, stigma-related questions, and kind of uncertainty about what's going to happen in the future. It's a little more nuanced and focused on AD. Not surprisingly, we saw that those who learned elevated results had increases in their concern about AD dementia, and those who had not learned non-elevated results had decreases in their concern about dementia. There was no changes or group differences in measures of future time perspective or subjective cognitive complaints. Our findings are similar to other reports. There was initially a large study looking at if there's any increase in psychological symptoms at 3 days after a person learns their amyloid PET result in a clinical trial context. So when they're completing a PET scan as part of eligibility screening into an anti-amyloid clinical trial, and there was no increases in these psychological symptoms. This was confirmed more recently through a meta-analysis that included that study, but also several other studies which indicated no short-term psychological impact of sharing biomarker results with adults without dementia. There are some additional variables that I think are helpful to think about and look at. For example, in this randomized controlled trial in a mild cognitive impairment sample, they found that amyloid disclosure did not clearly improve understanding or perceived efficacy to cope with a diagnosis of mild cognitive impairment. It's not exactly a psychological outcome, but an outcome of interest in terms of feeling like you can kind of cope with a diagnosis. That was not shown to improve after disclosure of results. So lastly, we looked at some behavioral outcomes. Again, these are really kind of preliminary, but what we did find was that those who learned elevated amyloid PET results showed an increase over time in the study in their interest in participating in lifestyle interventions, whereas this decreased in those who learned non-elevated results. We also found that those who, again, learned elevated results showed a significant increase in their interest in enrolling in clinical trials. This question was focused mostly on drug trials related to Alzheimer's disease, whereas this remained stable or decreased a little bit in those who learned non-elevated results. Finally, I mentioned that goal that we worked with participants to set at that post-disclosure visit, and we found that more than 90% of participants made progress on that goal at 2 months post-disclosure. But this was similar for those who learned elevated or not elevated results, so it didn't really seem like just learning an elevated result translated into more engagement in a brain health goal, but maybe it was more just kind of the goal-setting process that sort of motivated individuals to complete this goal. So overall, to kind of summarize this study results, we did find that this was feasible One thing I forgot to mention earlier is that we did do all these visits virtually over televideo for the disclosure visit. Some of the other visits were completed over the telephone. We found that 65% of our sample was able to do this from home, so completed all the visits from home. 35% of the sample needed to come on site for the televideo visit, which was the disclosure visit, because of limitations related to internet bandwidth or device, or just preference to wanting to be on site for this information. We did still have it from one room to another room over video to kind of keep it consistent across the study. And we started this during the end of 2020. So this was sort of why this was a shift into televideo, but it was a really helpful one to help us learn that we can do this and that we can then be flexible in some of our current disclosure practices in terms of how the video is set up or the visit set up. As far as psychological outcomes go, we found that this was safe. There was no increases in depression, anxiety, or suicidality. In those who learn elevated results, there is some increase in test-related distress and concern about AD, but all participants found learning their result was useful for them. As far as behavior, we did find that most people were able to make progress on a brain health goal, and those who learned elevated results were more interested in enrolling in clinical trials or lifestyle interventions than those who learned non-elevated results. There's limitations to this study for sure. This is a mostly white, highly educated sample of participants already enrolled in Alzheimer's disease research. So although these results may be useful for observational research studies, they may be less generalizable to the general population or clinical setting. We excluded participants with active depression and anxiety from this particular study, and the study did rely on self-report measures. So I'll wrap up by talking a little bit about future directions and practical considerations for disclosing biomarker test results. Over the last couple of years, there has been a shift in greater interest in providing results back to research participants. For example, this is from an article that came out a couple of years ago about recommending that we return or offer to return results from amyloid and tau PET scans to participants enrolled in studies who have MCI and dementia. And we should also try to learn more about this process, like who wants this knowledge, and for those who do, how will this knowledge might affect them and their families. The National Alzheimer's Coordinating Center also put out some guidance on best practices for biomarker disclosure last year. They also noted that ethical criteria for returning results to research participants supports returning results that are valid, interpretable, and actionable. They noted that biomarkers used for clinical care that are obtained similarly in the research setting require justification for withholding results from participants. So they have a strong stance that we should be sharing back these results from our research studies to those participants who have MCI and dementia. There's now been a real shift in our field with large consortia studies wanting to expand to include biomarker disclosure protocols, including the ADNI study, which collects amyloid and tau PET scans in many sites across the country, and the recently initiated CLARITY study, which will be collecting and harmonizing amyloid and tau PET data under Sterling Johnson, who's running that study across all the ADRCs in the country. This is really exciting because we've been able to help lead these processes with these new consortia. The ADNI disclosure protocol was developed by Dr. Claire Erickson, who's currently on postdoc at the University of Pennsylvania. And Dr. Nate Chin and I are leaders of the disclosure core for the CLARITY study. So we've been able to really take a lot of this knowledge that we've been working on and have developed over the last couple of years to help guide these larger studies. Additionally, locally, we've been building on this infrastructure that we developed to expand the option for amyloid PET disclosure to all of our research participants who want to learn these results. We found there was a big bottleneck in doing this, though. As you can imagine, it requires a lot of resources and staff effort. So we've also been working on building our team of trained coordinators and study clinicians who are available to schedule and conduct these visits and offer any post-disclosure support that's needed. And then we've been developing a centralized database where we can house all of the data related to these visits that's collected across multiple AD imaging protocols. We're gathering more participant feedback to improve this process and understand their responses and reactions to learning results. And I'm hoping we can use this as a foundation to build future disclosure science studies. There's many needs in this area. One is clinician training. One thing that we know from the dementia literature is that one barrier to dementia diagnosis has been a lack of training or confidence in the ability to diagnose and communicate the diagnosis of dementia. We asked our study clinicians who were involved in our amyloid disclosure study for some feedback and recommendations for us in thinking about how to develop a training materials. They noted that it's really helpful to have training on Alzheimer's disease biomarker testing and interpretation. They appreciated hands-on learning and collaboration across the team. They really would like more patient-facing materials to facilitate communication of results, and they felt it was important to allot an appropriate amount of time for these visits because they can sometimes take a while if people have lots of questions. We're also interested in looking at this question about behavior change. So, we've seen that those who learn biomarker results or anticipate learning biomarker results are expressing interest in engaging more in health behavior to reduce their overall dementia risk. And so I think it'll be helpful for us to better understand if people engage in behaviors, what sort of changes as far as health beliefs that maybe motivates them to engage more in health behaviors. And is there any kind of support that we need to put in place to facilitate that engagement in health behaviors at that time? There are also cultural factors that are really important for us to be aware of. There's been most studies in biomarker research have been conducted with non-Hispanic white populations. This is starting to change, but there's still a lot of work to be done in this area. And so we still need to learn a lot about biomarker testing in non-white populations. Is there any differences in terms of interpretation of the results in relation to other factors like comorbidities that a person might have? And are there cultural factors related to the communication of the results and the recommendations that we can then develop and disseminate to clinicians and researchers who are doing this work? If you're interested in doing biomarker testing and disclosure in the future, there was a paper published last year by Emily Largent and colleagues that described a 5-step process for biomarker testing and disclosure, which I think can be kind of a useful kind of primer on how to go about this process. So step 1 is to determine the appropriateness of biomarker testing and return of results for this particular individual. Step 2 is to provide some pretest education and seek informed consent. They recommend that we assess what the individual already knows, provide some education about cognition, Alzheimer's, and biomarker testing, assess appreciation and understanding of this test and what the results can mean, and then seek consent. Step 3 is to administer the biomarker test. And then step 4 is to return the biomarker test results, again, through a process of assessing what the individual already knows, confirming they want to know their results, returning the results using non-technical words, small chunks, pauses, acknowledging emotion, which is really important as this comes up often during these visits, ensuring that a person understands the results and helping them to prepare for next steps. Step 5 then is, a check-in and providing opportunities for follow-up as needed. In considering biomarker testing, it's helpful to think about the purpose of the biomarker test. Blood-based biomarkers may be more appropriate in the future for screening or kind of maybe initial diagnosis along with other information, whereas PET scans can be really helpful for disease confirmation and staging, since we can see that spatial distribution of amyloid and tau? What setting are we in? Is it a clinic? Is it primary care where there's not a whole lot of time and lots going on? Or is it specialty care where we're really digging into a memory diagnosis, memory disorder diagnosis? Is it a clinical trial where we're doing these biomarker tests to kind of enroll people who only have amyloid plaques, for example? Or is it an observational research study like what I've been talking about today? What's the patient context? They already have a neurocognitive disorder, or is this kind of a part of that workup? Are they a cognitively healthy adult enrolled in a clinical trial, and this is more about risk? Are they represented in the biomarker validation trials? And do they have a support system on board? This area of research is still in its infancy. It's kind of new, but we do have a kind of a working group called Agreed Dementia that I'm a part of, and we have some webinars and toolkits on the website if you are interested in learning more. So I think I'll wrap up by just asking the question, why should I care about this? We do testing and provide feedback on results all the time. What's different about this, if anything? So the way I think about this is kind of, we know that early diagnosis of dementia is really helpful. We know this anecdotally from patients and families that we see in the clinic, and we know this through research studies that have looked specifically at these kinds of questions. But unfortunately, what actually happens is that many people who meet criteria for dementia are not diagnosed. Only half of Medicare beneficiaries who are diagnosed with dementia are actually told the diagnosis. So there's a barrier to getting a diagnosis. There's also a barrier to communication of the diagnosis. Diagnosis is lower in non-white populations, even though we know that Alzheimer's disease actually is higher in populations or non-white populations, but the diagnosis happens less. And less than half of those with cognitive impairment receive recommended additional diagnostic services. So sometimes there's this thought of like, there's nothing we can really do about this. So I think these biomarker tests are so helpful and may increase earlier diagnosis, preventative strategies, and treatment for Alzheimer's disease. But in order for this to be kind of translated into making a difference in someone's life, we need to also have additional education and support about how to interpret and communicate the meaning of these results. If there's any, validity for different populations across the disease spectrum, and how these tests can inform our diagnosis and specific recommendations. So I'll stop there, but before I take questions, I want to thank all of our RAP participants and ADRC participants who volunteer so much of their time to help us learn about Alzheimer's disease and also motivate us to engage in new research such as this area of research, and help us to give us feedback about how it's going so far and what we can do better. I also want to thank the study team and collaborators who've been involved in these projects that I talked about today. It's not just me. It takes a huge team to do all of this work in terms of design, data collection, analysis, dissemination of results. So I'm so grateful to all of them for kind of being on this disclosure train with me. And I'll thank you all for your attention this morning, and happy to try to answer any questions that you might have. Thank you.
Great. Well, thank you, Dr. Clark, for a wonderful overview and some of the exciting research that's being done and engaging with the patients in these decision-making, in shared decision-making. So I'm going to try to combine a couple of questions and maybe ask a global overview. The studies that you are doing have focused on the patient and educating the patient, disclosure to the patient. Have you looked at the impact on families or caregivers for disclosure information and what their journey is in all of this?
That's such a great question. And the answer is no, not yet. But that is something that we are interested in doing next, is adding some additional surveys for our study partners involved in these studies and getting more information. There has been some studies more in the MCI and dementia literature, looking at care partners' reactions. And there has been some reports of caregivers sometimes feeling distressed about the results or feeling like they don't have that perceived efficacy to cope with the partner's diagnosis as well. For example, that MCI study that I mentioned by Dr. Lingler. So there's a little bit of work happening in that area, but there needs to be more research done.
And then along the same lines, are there any clinical ramifications in terms of family testing of patients who test positive of high biomarkers and cognitive decline, or any recommendations for genetic testing, ApoE, allele testing, et cetera?
Yeah, great question. We typically talk about this result as just it's a result for the patient. It doesn't have specific implications for their family members. So although their family members may be at higher risk for developing Alzheimer's disease because they have a family member who has these markers, that we don't know that that's true. We don't know that family history isn't always a strong correlate. Although those who have elevated markers of amyloid are likely to be, they're higher, more likely to be ApoE4 positive or have that genetic risk factor. So we haven't really explored that too much in terms of recommending specific genetic testing or anything for their families, but we do talk about that they may be at a higher risk for Alzheimer's dementia in their future as well.
And then for those patients who have some mild cognitive impairment, but test negative for the biomarkers, what are the next steps?
Yeah. These can be hard sessions because people are then a little bit more confused about what could be causing these symptoms. So typically we'll recommend, sometimes we'll recommend a memory clinic evaluation if they haven't had one already. So sometimes people haven't actually seen a memory specialist, and we'll let them know that there are many other factors that can cause mild cognitive impairment. They may want to talk with their doctor about medications they're taking. Labs could be run. Additional structural MRI imaging could be done if that hasn't been done yet. We talk to them about other factors like depression, sleep, alcohol use. And we do know some of that information from the research data that we have because they have a full kind of workup as part of our study. So we do talk with participants, I see that your depression score was really high here, and depression can impact, your ability to pay attention and remember information. Have you, may want to talk with your primary care provider more about that and see if a referral would be recommended for you.
Great. Just trying to, I think, how do you think the development of new targeted therapeutics has impacted research on biomarkers and particularly disclosure of the information now that there is potential therapeutics?
It's impacted it a lot. When we first started this study, there weren't disease-modifying therapies yet. And there was hesitation about doing this work or about providing these results back. As soon as even the first FDA-approved therapy, which I didn't really talk about today, the aducanumab, when that was approved, it was an immediate shift to wanting to provide these results back to participants with MCI and dementia in order to ensure eligibility for that therapy. And that's continued to grow with the newer like lecanemab coming out. So it's been a huge shift in the research. It's like a 180 actually of how, researchers now want this information out. So I think, having therapeutics makes a big difference in terms of people actually wanting to test for Alzheimer's disease. I think there's been a big lack of providing or wanting to diagnose dementia due to Alzheimer's disease historically, because one of the thoughts has been like, well, there's nothing to do. Although those of us who work in this area know there's tons to do actually, and that just this disease modifying therapy isn't the only answer. But this has been a big shift towards, well, now there could be like a treatment. So it's changed things a lot.
Great. Sanjay, I can't tell, do you want to ask a question? So another question about promoting brain health and the non-therapeutic interventions. From your study, what is your follow-up? How long do participants stick with the brain health, the pro-brain health activities?
Yeah.
First question.
So that's something I have to look into next. So I apologize that I don't have that answer yet, but that'll be the next analysis I'll be conducting, is to see. We did ask them at that final time point about how long. And my preliminary data, which was looking at about half of this sample, showed that it was still high, but it wasn't as high. It was like maybe 75% had still kind of stuck with that goal. But I need to rerun that analysis now that we have the final completed set ready to go. And I think that is a good question, because we know that people might start a goal, but then not maintain it over time. And so I think that's a really important thing to look into.
And for those who test negative, do you still counsel on brain health activity? You know, because they seem kind of common sense activities. And is there any any views of, oh, my tests are negative, I don't have increased risk, I can go out and do whatever I want now, give me permission to continue smoking or continue this or that?
Yeah. So we did see that our non-elevated participants were much less interested in making a change into their lifestyle than the elevated participants. So I do think that's part of the issue. We do still do the risk reduction counseling visit with those, because we feel like these are helpful for brain health in general. And so when I initially looked at those analyses at 2 months, there was similar rates of progress on goals across even in the non-elevated group. But whether that maintains differently in that group is sort of the next thing I'll be looking at. And certainly their interest and their motivation was lower.
Yeah.
Which is kind of a bummer, because we know that all of this, these lifestyle changes are not specific actually to Alzheimer's disease. They're more specific to building up cognitive reserve and resilience to the brain.
Yeah, it's interesting. We had some similar results with the lung cancer screening process. If their CAT scan was normal, like, oh, I can continue smoking, it's fine. Like, no. Wrong take-home message from this.
Yeah, and I think that's a good point, because there might be some work we can do in terms of providing more education to those with non-elevated results. You know, that this is good news, this is a relief, but there's still other conditions that can develop with aging that we can be proactive about, kind of trying to fight against.
Yeah, so thank you. And I'm just trying to read another question. So if amyloid beta is less frequently, elevated amyloid is less frequently detected in Black participants, but the clinical diagnosis of impairment is more likely. So where's that disconnect? Is it that the measures of our cognitive impairment are faulty, or are there other causes of impairment that are masking as Alzheimer's?
Yeah, I can give you a couple hypotheses, but I think the answer is we don't really know. And also it's found in some studies, but it's not found in all studies. But one hypothesis is that it's possible that those non-white participants have MCI and dementia that's more due to vascular risk factors, for example, like diabetes, cerebrovascular disease, et cetera. And that this is contributing to higher clinical diagnoses, but there's actually lower rates of amyloid, positivity. Another potential component is recruitment differences for white and Black participants into research studies. Sometimes there's a difference where white participants may be recruited from a clinical sample, like people who had a family history or a parent who was in the memory clinic, and those individuals will end up being higher. At higher risk, whereas Black participants, there might be like more community participatory based research strategies, and then we're just kind of recruiting these different people. So I think there's still, the jury is definitely still out, but it's confusing. And what I'll say is when we disclose now, we're continuing to do this. And when we disclose with a person of color, we just provide some of the caveats in our interpretation that most of the biomarker data that we have is on white participants. And so we just don't know if like the meaning or the prognosis is exactly the same. And so we always bring that up as part of our conversation and discussion.
Great. And then the final question is, with the increasing availability and advent of genetic testing, home genetic testing, 23andMe, et cetera, do you have participants coming in and saying, hey, I've got told I have a higher risk for Alzheimer's, and how has that impacted your recruitment or your study, et cetera?
We do have that sometimes happen, where participants will have their 23andMe test and bring it in and want to talk with us about it, which is fine. We're happy to kind of chat about what that means. And I don't know that it's impacted our recruitment per se. One thing we haven't looked at is, if someone knows their genetic risk factor already, does that impact how they learn their amyloid PET results? And that might be something we could look at, which I haven't really thought about until just now. But yeah, we do have that happen.
Great. All right. Well, we are at the hour. Thank you so much for an illuminating talk on what's happening in biomarker discovery for Alzheimer's, and more importantly, and how we interact with our patients and the impact of disclosures on our patients. So thank you for your work and for your presentation.
Yeah, thank you so much. Happy to be here. Take care.
Thank you, everyone.
Bye.